Dr. Sameer Kulkarni is a seasoned healthcare executive driving clinical excellence, digital transformation, and world-class patient care standards. So we also have one more panelist, Mr. Saurabh Gupta, Regional Director, Mumbai KIMS Hospital, but he's on his way. He'll be joining us soon as he arrives. And Mr. Saurabh Gupta brings strong leadership in multi-unit hospital operations, business expansion, healthcare service excellence across one of the India's fastest growing hospital network. With this, I hand it over to you, gentlemen. Thank you.
Good morning, everyone. First of all, thank you, Aristocrat Media and Farooq, for having us here. I know we are running late, so I'm going to push and try and get this done as quickly as possible. So, distinguished ladies and gentlemen, the last 2 decades, India has achieved something remarkable. We have built, we have expanded, we've invested. Bed counts have risen, hospital chains are moving to new cities, corporate healthcare is becoming a creditable industry. But the question that I want to place before this room, before we begin, if we have so much of growth, why are still 55 million Indians pushed into poverty every single year due to hospitalization? Why do 40 crore of our fellow citizens, that's equivalent to the population of the United States, still fall in the gap between the PHC that they have outgrown and the private hospital that they cannot afford? And why this country, with a proclaimed $5 trillion economy, spends only 1.9% of its GDP on healthcare? The answers are very uncomfortable, but necessary. We've confused growth with this progress. We built volumes, but what we should have built was a system. So the core argument today is going to be what sustainable and scalable actually means. Sustainability of institutions, scalability of institutions, and affordability to the common man. In this panel today, we have very heavy healthcare leaders, sharpest, who manage operational complexities of institutions that serve thousands of patients daily. People who know the distance between a well-governed hospital and a poorly governed one. My job today is simply to ask the right questions and to make sure that by the time we are done, which as I've been told is 12:30 non-negotiable, what should be done, not for the industry, not for the balance sheet, but for the 140 crore Indian population that wants to get this right. So let's begin on this note. My first question is going to go to Joy, who's an old friend and someone who I've always looked up to. Joy is the CEO of one of India's most respected tertiary care institutions, an institution that's a benchmark that the entire city and the country looks up to. But benchmarks can also become burdens. As a CEO, he's responsible for sustaining operational excellence on scale day after day across every department. Joy, the question is, in your experience, what is the single hardest thing to govern inside a large urban hospital? The thing that no accreditation framework fully captures, and how do you keep institutional quality from quietly degrading even when the dashboards look green?
Thank you, Ahmed, by telling my old friend, I don't know what is the kind of image you have given about my age, but still I feel that I'm pretty young in the healthcare industry. I have spent close to 28 years, and every day I'm learning. And some of the points what you have started, and before coming directly to the answer of your question, I want to tell you, fantastically, Dr. Bhattacharya has given the, set the tone, and he has expressed the aspiration of Indians, what we want. Parallelly, you have given some of the clues like 1.9% of GDP, what government spends for the thing, for the Indian healthcare. We know the kind of bed is to patient ratio and all are there. But the biggest dichotomy, US spends 18% of GDP on healthcare, and in UK 40% tax is taken and taking care of education and health. Still people are unhappy. So I don't know why people should be happy even in India with 1.9%. The dichotomy is we have huge expectations, and it is becoming more and more and more, but our ability or willingness to pay for the services are comparatively lesser. Little digression from my hospital experience, very recent. Right now, there is an exercise going on with IRDAI and hospitals. The insurance consortium, they are trying to get things in place that how do you standardize service, care and all. Always insurance companies are talking about that my expenses are going up, my claims ratios are shooting up. You have to give a package what I can manage, without thinking that we are not willing to pay higher premium for a better service. But we want high quality service, want to pay less premium, burden on insurance. Insurance is pressurizing hospital, and ultimately hospitals are under pressure in front of the patient that I should do the best possible thing, retain my market share, and see my patients are going out happily. And there my experience comes from Hinduja hospital. When we come across, and you told one challenge, mostly what you face every day, how do you meet and match with your patient's expectation, meet their experience and ensure that what you are delivering, it is up to the mark? During that, as you also told that metrics, targets and KPIs, whatever is involved and what we look at every day, I feel that we are going to face more and more challenge as we intend to get different governmental scheme. I'm not against those, but when you try to get them and you need to give this high quality care back to the patients, then how it is going to be possible? Recently, there was a revision of these packages of insurance companies, and they had cholecystectomy, lap cholecystectomy and package approval of 55,000 rupees. And recently when I met the CEO of GIC, he was very open and very proudly told that you are going to increase it to 75 to 80,000. Still I thought how it is going to be feasible for a hospital like, whether it is Hinduja or any other comparable hospital in Bombay, still to give that care at 75 to 80,000 rupees, what is expected, and without knowing how long this package rate will continue. But we need to remain committed. So what we do in Hinduja hospital, we have, with due respect again, we have not gone for many of these insurance companies in empanelment. We don't have GIPSA, we don't have any of those, Ayushman Bharat or any other of those scheme. What we try to do, we try to make a balance between people who are coming and knocking our door. Like, 20% of our beds are either free or subsidized. How do you cater to them? Like a Robin Hood concept, by making money from the people who can give us. We don't distinguish in terms of service quality between a patient who is paying and who is not paying. And I'm again emphasizing in the same category of bed, when a patient is paying and not paying, there is no difference in the type of services what we give. We have made the process flow in such a way that everybody makes or the other gets the service in the most efficient way. And the second aspect of it is we have taken a lot of this business excellence model like Lean, Six Sigma, Quality Circle kind of tools we have adopted and made the process as lean as possible. Though the hospital is 75 years old, but we are trying to become as young as possible with the digital, with the IT infrastructure, with the kind of care delivery system we are making. We are trying to see how that can be make much better for the patient. Input costs have been reduced, and I'm very happily I can say, I can share that probably the material cost what we have in our hospital, that is the lowest amongst the all tertiary care private hospitals in the country. Multi-speciality, not single specialty. So these are some of the things what we have done.
Thanks, Joy. I think that's exactly how you answer the last point, keeping institutional quality from degrading. And you've answered it very well. Thank you. My next question is to another dear friend of mine, Dr. Akash Rajpal. Akash, you've had roles of a CEO, COO across various institutions with different cultures, different patient profiles, different financial models. Jaslok and Masina Hospital are both iconic names in Mumbai and in India. What did moving between these institutions teach you about what governance structures actually transfer? And what looks like a best practice in one setting does not survive the transplant to another? Remember, you served two hospitals, and you've served two different types of Indias, because both your catchments were different. So over to you.
Great question. You know me so well. Not just Jaslok, Masina, but also Hiranandani Hospital when it started in Powai. Before that, government hospital, chain of primary healthcare centers in Navi Mumbai Municipal Corporation as a government officer, and then even management consulting firms, seen everything. And Medica Bazaar, India's largest supply chain platform, leading the sales vertical out there. Seen everything, but I'm telling you, one thing I've learned which is very common to all of those things, and I'll talk about the diverse aspects a little later, is logic will only get you approval to get things done, whether it is scalability or anything, but it's only the alignment with the key stakeholders which will get you execution. On paper, everything sounds all nice, logical. You get the best of approval and then say, nothing like that they have seen before. But when you go down to execute things, unless your key stakeholders, say in a hospital, it is a doctor, patient, insurance, if they all don't come together, agree to what you want to do, nothing is going to work on the ground. And I found why that happens. I've learned it a hard way in a certain sense. The organizations don't scale keeping in mind standardization as a core principle. Organizations scale keeping in mind the contextual stability or consistency. When I mean to say contextual consistency, it's more philosophical than it sounds technical, is you have to read between the lines. You may be hired to do a certain thing, but the promoters may have thought of certain things. They may have seen your success in some of the organization. They want you to replicate it without stirring the the bee's nest. So that contextual stability is something which I feel, as a leader of the organization, you have to find that as quickly as possible. Unless you do that, what would happen is what you have done successfully in some organization, if you try and do that, you will end up facing a lot of resistance. I'll give you a practical example. In one hospital, with a lot of support, I did daily reviews, dashboards, some unique metrics, very specific to that organization, and then it worked wonderful. There was a lot of buy-in also. Same thing which I was hired for, and I did that in some other organization, there was a lot of fight back from the doctors, even the care providers. Later, the board members also started asking me, why are you trying to do this? A lot of doctors are complaining that, why are you making them accountable? So, you have to understand quickly why this happens, and that is one of the biggest reasons why a lot of organizations don't scale fast. So it all depends on the institutional ethos or the risk to stir the bee's nest. At the end, how quickly do you want it? What is your will? Whether you want to even do it. So that, I think that is the reason why it doesn't happen, and that is what I learned. And that is where the scalability stops.
So you agree that a best practice in one setting may not necessarily...
No, not at all.
Thanks.
Even within South Mumbai, for example, Jaslok's premium setup, pricing structures, customer acquisition model will not work in a very setup like Masina, which is a very diverse socioeconomic setup, a very different kind of a brand perception. Though they are just few kilometers apart, the perception is very different.
That's exactly what I said. You served two different Indias in South Mumbai. Anyway, thanks a lot, Akash. My next question is to Dr. Anupam. Anupam, you are a CEO of the Hiranandani Navneet Hospital, and you sit at an intersection where clinical ambition meets financial reality single day, and every single day. Mid-tier hospitals like yours are very important because they serve the community at large. You are expected to deliver quality that competes with the larger chains. In your honest assessment, is the financial architecture, that is payer mix, Ayushman reimbursements, insurance tariffs, actually designed to let mid-tier hospitals like yours function effectively and act socially responsible? Or are we asking a question which does not have any balance?
Very good afternoon to everyone. Thank you, Aristocrat Media and Farooq, for having me in this panel. And thank you to all the panelists over here and moderator Ahmad. He has really moderated the question very moderately. So I would only say, look, even he knows the answer of this very, very well. But still, I would say the balance is not in an equilibrium, of course. To be honest, it is not in equilibrium. Because the needs, what the government sector takings are, is very different than how a hospital runs. We have to match, cross-subsidize somewhere, and we have to play a volume business game. Simultaneously also, there is something which is called accessibility to the care, for which we are really competent for. I mean, say, for example, my hospital doesn't have a OBGY setup. So if I take something from the government, which should be completely, is not, I am not serving the purpose. Second is that the accountability. Like, are the patients coming to me, whoever, from the government, non-government sector, are we able to fulfill their requirements? Because the match does not happen. The doctors who are there in my hospital are honorary consultants. If I put them as a fixed consultant, a fixed salary consultant, then of course the costings become very high. Then we have to play a different kind of a strategy to satisfy our business. It's that way. And third is, of course, we look into outcomes, that how do we help these people, we have to sustain somewhere with the business. And how do we do it? So there are a lot of plans which we make. There are a lot of areas where we go into and we basically bring in the patients. Simultaneously, I would tell you, like, it's a government hospitals. We had recently CGHS with us. We are just discontinuing that because, again, the costings becomes the pricing becomes very, very problematic for us. It's difficult. My doctors do not want to do it with that kind of amount. But there is a plan for it also, because in D.Y. Patil Hospital, I did it in a different plan, wherein it was a sustainable model. But when I come to a small or mid-sized hospital, it becomes very difficult to sustain, because my consultants are not my full-timers, whom I can just tell, whenever you come and you do it. So the answer, I would say, it's balancing. It's very, very difficult to balance.
Thanks. Thank you. Anuj, Dr. Anuj Tiwari. Yes. Next question to you. Just to let you know, most healthcare conversations in this country happen in Mumbai, Delhi, and Bangalore. And we wonder at times why it does not reach places like Nagpur. You are operating a significant large hospital in Digdo, which is not in the heart of Nagpur, but its periphery. Serving a population that is largely dependent on secondary care that simply does not exist near them. Tell us honestly, what does financial resilience look like when your patient's population ability to pay is limited, your referral chain is fragile, and your nearest competition is also the nearest collaboration? What keeps Lata Mangeshkar Hospital not just open, but genuinely sustainable?
Good afternoon, everyone. Thank you, Mr. Farooq, Aristocrat Media, and my dear colleagues on the dais. This is a very good question, Ahmad sir. Nicely taken on. So, sustainability of a hospital. What is Lata Mangeshkar? Let me tell you first. We are around a chain of hospitals, approx 2. One is in the heart of the city, around 200 bed, and the other one is around 1200 beds across, a little distance from the city, not away from the city, you can say. So, we have to run two separate different models. In the heart of the city, we have a combination of all things, like Mr. Joy and others have said, that we have a mix of cash, insurance, TPA, schemes, multiple schemes. That is a mix in the city. And also in a little, hardly 8-7 kilometers from the center of the city, we have our second hospitals, which we have to feed a lot. It's a Herculean task at times to fill around, not possible average, still to maintain a 60-70% occupancy is very tough for a huge setup. And Nagpur, being now it will come into smart city soon, it is also becoming the third healthcare hub across Maharashtra after Bombay, Pune, then comes Nagpur. So it is developing, but it is, the Lata Mangeshkar is a set of, I can say, secondary and tertiary both. We also do high-end onco surgeries, transplants, either replacements and everything. Parallelly running the setup of around, you can say, average 700-800 occupancy is a mix of many things. Mostly we have to also cater with a lot of schemes. At times you have 1,000 patients also. So it is a mix of schemes, cash, insurance. Again, schemes, not only you can say CGHS or ESI, MPKY, it has to be a mix of multiple government, semi-government and other parameters. Also, we have tie-up with RHCs and PHCs, and we are working on the PPP model with many places. Approximately it may be 20-25 area zones which feed us. So we try to create a hub and spoke model. And also at Bardi, that is the center of Nagpur, they also send us for tertiary cares. So Lata Mangeshkar, I can say the hospital is definitely a mix of secondary as well as tertiary.
Thank you, sir. My next question is to Saurabh. Saurabh Gupta is the Regional Director, KIMS Hospital, Thane. Saurabh, KIMS is one of the most interesting expansion stories in Indian healthcare. A chain that has deliberately moved into geographies that larger networks have considered too difficult or too thin on margins. Thane is not South Mumbai. Patient expectations are different. The payer mix is different. The talent availability is different. What does it actually take to transplant the KIMS operational model to a new geography, and where have you found that model to adapt rather than simply replicate?
Okay, so thank you, Ahmad, and thank you, Aristocrat Media, for having me here. So before I get into the question, I'll actually tell you what happened this morning. So I'm traveling from Thane, and it took me 3 hours on road from Thane to this place. So I always used to say that access to healthcare in India is controlled by affordability. But it's not just that. Access to India is controlled by affordability and geography. So just imagine if a stroke patient or patient in MI has to travel 3 hours on road. So one thing is very clear, that we are looking at, decentralization of hospitals. So especially after COVID, this is happening, every 5 kilometers, 10 kilometers, you need a hospital. Because, the travel times and the population density is so much, people won't be able to travel and don't want to travel. And that is the reason you see a lot of beds. There are 35,000 beds which are coming up in India in next 3 years. 65% of those beds are coming in tier 2 and 3 tier cities. Okay, now coming to KIMS. So KIMS actually challenged some of the preconceived notions that you need to start from a tier 2 city and then go to tier 2 city. No, we started from a tier 3 cities. A group of doctors led by Dr. Bhaskar Rao came together, and we started from a city called Nellore. Now the difference in model was that instead of getting PE money or getting money from the bank, doctors pooled the money. They made a group practice and they started. They were very clear that the healthcare has to be affordable. And still, 55% of our beds, we run 9,000 beds across the country. 55,000 of our beds are in tier 2 and tier 3 cities. Now, how we have been able to replicate some of the successes, and our margins are among the top 3 in India with the leading operator, despite being affordable. So our ARPOB is almost half of what leading operators have. But still our margins are as good as our ROIs are, the second best in the industry. So, there are 2-3 things which are core. One is work with doctors. Do not manage the hospital. Give whatever doctors need for them to perform. Take the administrative burden out of their head and just allow them to flourish. Invest in technology. Of course, some of our hospitals are as basic as, they have tiles in the hospital, and some of them are, of course, world class. But there is a mix and match. So we see what type of city we work in. Like Thane is an example. So again, in some of the cities, like we have presence in Nagpur, we have presence in, some of the smaller cities in Andhra. So if a city has a population of 25 lakhs or 20 lakhs, there is no reason the healthcare distribution or the disease distribution will be different. And that we have seen. In places like Visakhapatnam, Nellore, Rajamundry, we are doing lung transplants. People thought it is not possible, but we have actually changed that philosophy because the disease pattern was there. People were traveling. That is stopping. Of course, the per capita income and the reimbursement rates are lower, but so are the costs. And what we have seen in Thane is that the payer mix is almost similar to South Bombay. The prices are 10% lower, but my ARPOBs are crossing 70,000. So, in no way, Thane is, I would say, less fertile or it is less...
70,000 ARPOB is
yes.
a damn good
So,
ARPOB.
that's what I am saying.
Joy, any comments?
Yeah. Only comments, there is no external people. If they hear, they will think hospitals are maintaining money.
Yeah. So, by the way, we also do one of the largest number of Arogyashi patients in, and almost significant percentage of our discounts are, so KIMS is known, the last thing is KIMS is known as a hospital where no patient generally is turned away. We recently completed 300 congenital heart diseases patients. Yesterday was the celebration. And congenital heart diseases are patients who hardly can pay. So Rotary and other people, and even hospital collaborated. We have 2 foundations of our own. And that's the reason our RPOBs are lower. But just Thane, I'm saying, Thane is no way lower strata economy than Bombay. But we manage. So, thank you.
Sure, fantastic work being done by you all. My last question for this first round, there is one more round after this. Dr. Samir Kulkarni. Samir, Hiranandani carries the weight of a legendary name and the expectations of a community that it has served for decades. As a CEO, you are the custodian of that legacy. But legacy can be both an asset and an anchor. The question I want to ask you is about outcomes accountability in an era where patients are more informed, regulators are more watchful, payers are beginning to move towards value-based frameworks. How do you build the culture in the hospital where clinical outcomes are not only just reported, but generally drive decision-making? And where does governance end and medical leadership begin?
That's a good question. Hiranandani is a very good hospital. It's the first NABH accredited hospital in Western India. I think Akash sir was part of that journey. So, in terms of governance, we have some 200 operational parameters. It is not restricted to Hiranandani Hospital. It is with Fortis, with Paras, with Medanta. For all hospitals are now coming up with operational parameters which we follow on a regular basis, and it takes care of the results. So clinical outcomes are taken care of through a particular operational processes that we drive. So we are more process-driven organization. Everything is related to SOPs, and we follow those SOPs in spirit and in reality. So that gives us a very good result, very good outcomes. All our doctors are with us since 20 plus years, so they know the processes. 80% of our employees are more than 10 years old in the system, so they know the processes. So everything is kind of well-oiled machinery, and we ensure that we deliver good outcomes. Thank you.
Thank you. That is fast and quick. Moving on to the second round, opening batsman Joy Chakraborty. Joy, let me bring in a dimension that every hospital CEO is wrestling with: AI and machine learning. We are hearing extraordinary claims that AI reads radiology faster than a radiologist, predictive algorithms that flag deteriorating patients before the nurse does, operational tools that optimize bed allocation and OT scheduling in real time. At Hinduja, you have the scale and data to actually pilot these meaningfully. So cut the noise for us and tell us, where is AI generally delivering operational clinical value? And if I ask you to think 20 years ahead, what will a fully AI native hospital actually look like? Not just smarter radiology or predictive alerts, but end to end from triage to discharge to post-care.
So it is not the opening batsman next round, it is the slog over, so you have to be very fast. So
go ahead.
Yeah, so first thing what we have done in the hospital, we have formed a AI strategy and implementation committee. It consists of multiple stakeholders from different background. As you told, what we are doing with so much of data, so very carefully we are evaluating different applications, whatever is reaching to us as well as whatever we are reaching out. How we are doing that? We have made a roadmap for the patient's journey as well as in the research area, that before the patient comes to hospital and after discharge, if you see the whole patient journey, each of these touch points, what are the applications we can take? We have come across, I think like me, all of us on the dais, I can tell you that hundreds and hundreds of solutions have come. We are very conservative. We are taking very, carefully that what to take, what not to take. 3 to 4 applications in clinical areas we have adopted, and of course, 2 of them are in radiology. But just to complement your question, that it is not that we are thinking that AI is going to take over. We are keeping the radiologist and AI together, because it is not that they are going to replace and tomorrow we'll be only working on this AI tools and we'll be treating patients on the basis of that. However, there are several of those applications have come in the non-clinical area where process improvement, efficiency and all are there. 20 years down the line, what do I see and predict? I foresee that, the way, I'll tell you, in 90s, the computerization happened. People used to ask on those days whether you are going for computerization or not. So people used to say, no, I can't get rid of my people, I have to have computer. But the concepts have changed. Today we don't ask a question whether you are computerized or not. Now our question is whether you are digital or
digitized or not.
Yes. So the situation will be like this. All these today, if I buy a MRI, CT and all, every company comes and talks about there is an inbuilt AI engine sitting on this and they are going to give you this value addition. So there is nothing that you buy MRI and then go for this tool. It is sitting on this. Similarly, in all these areas, I assume and I anticipate that 20 years down the line, all this will be integral part and that will bring a lot of process efficiency and productivity.
Thank you. Akash? By 2047, the idea of a hospital as a standalone entity may itself become an outdated one. Care will be distributed across home, diagnostics, digital platform, community networks. If governance today is hospital-centric, what will governance look like in a networked ecosystem?
2047 is too far off. We didn't know what, just 2 years back, we didn't know that ChatGPT would come in and change our lives. We don't know what would happen in 2047. But I am pretty sure about one thing, that the patient-doctor personal physical interaction is highly underrated commodity or a value, which I don't think will ever go away. No matter how many AIs and robots, all of those things come in, those would just be like your keyboard as a tool to make your decision-making faster. Governance could become better, where most of the underlying things like getting admission or appointments, etc., may be automated. But ultimately, getting that prescription decision done will have a human interaction, because that will never fade away, which has not faded away since eons. We have been seeing whether it was the Hakims and the Ayurveds or the Vedic doctors, etc. We have always seen that physical touch is always there. So I don't think that will ever go away. In terms of governance, which I'm seeing is, which even the present government is trying to say, is that they're putting in power more to people rather than the bureaucrats. So I think that'll happen more and more.
That's exactly my question. How will the governance be in a system like this?
See, governance has 2 parts. One is the bureaucracy which executes the policy, and the other is at the decentralized level where the actual execution happens. The centralized part will become much more leaner, much more AI-driven, including the initial level of laws, etc. But when it comes to the decentralized part, that will always be the personal interaction. It will always be that way.
Right, thanks. Bus, le lo mic. Dr. Karmakar, in round one, you gave us an honest picture of the financial pressures facing mid-tier hospitals. I'm going to push that further now. Because the structural problem you described is not unique to Hira Mongi Navneet Hospital. It's a defining challenge for hospitals across India that are doing exactly what Viksit Bharat needs them to do. Serving the middle class, staying in their communities, refusing to abandon patients who cannot pay, yet finding themselves financially squeezed in every direction. So let me ask you this question directly. What needs to fundamentally change in Ayushman's reimbursement structures, insurance tariff negotiations, public-private partnership models for a mid-tier hospital to be genuinely financially sustainable while fulfilling a social mandate?
Okay, fine. Yeah, so I would let you know, there are models of hospitals. Like there is nursing homes, there is hospitals of 100 bed, 50 to basically 200 beds, and then after furthermore the bigger bedded hospitals, medical college hospital as well. So, you know, if you ask me, like when the model of a charitable hospital is being designed, it has to be designed with a proper costing kept in mind. It cannot be designed with the whims and fancies of what they want to do. And if whoever is designing that thing should also keep the balances. You want to say something?
Yeah, so I hear what you're saying. When I asked that question, from reimbursement, insurance, public-private partnership, which is that one policy lever that you would like to pull that could see a immediate impact?
Basically, the timeline for the reimbursement should be the least. That kills us, in fact, because there are creditors who are standing in the queue and we have to give them money. Even they have to get it from somewhere. There are vendors in line, there are doctors' payments, there are salary structures to be fulfilled. So basically, the reimbursement should be very well in time. In fact, Dr. Ahmad himself has faced this with the government authorities very much. So you know the pain of that. Okay, how does it happen that when you have to give money to somebody and you have not received it back from the government to basically fulfill those needs?
So that's a national policy point that we enjoy for you.
So, you know, you need to have cash flows in place.
Absolutely.
So to run any organization sustainably, you need to have the cash flows. So to get the cash flows done, the challenge for the hospital will be how quickly you recover and how do you keep that in control. Some of the schemes you took name may not be very good example for hospitals to adopt, but just to look at it from the occupancy, business point of view, they surrender and then, you know, who is going to dictate the term that kind of situation arises.
Saurabh, my next question to you. It's a great honor that KIMS holds a distinction that no other institution on this panel can claim tonight. You have formally published a BRSR report. In a sector where ESG is still largely treated as a compliance checkbox, KIMS has made a public commitment to environmental, social and governance responsibility. When KIMS commits to reducing the carbon footprint, to reduce biomedical waste, does that actually change and how?
So thank you. I think that is a very pertinent question and a comment. What we do is that ESG is actually something which is imbibed in every CXO or every unit head. And let's talk about ESG things. So, you know, we have done things at the corporate level, at the unit level, like, you know, in Thane, if you come, there will be a lot of environmental factors. So we don't use plastic bottles. We use, you know, recycled glass bottles. We have a composting machine on site. We have a, you know, Rotary, we work with Rotary. They donated us with a bottle crushing machine. So, you know, plastic bits can be recycled. So small things we have done. We use jute bags. We use solar in half of our hospitals. So even Thane unit will be going for solar. So we do a lot of things for environment. When it comes to social responsibility, we actually have a tie-up with Tech Mahindra. So we train a lot of people in-house, and we take these people from lower strata of the society. So they, get trained, and this is part of the Pradhan Mantri, Yojana also. So they get trained, they get absorbed in our hospitals. When it comes to governors, our internal controls are very strong. It's a stock market listed company. And apart from that also, we have, as I told, two foundations, Little Cure Foundation and Kim's Foundation. We do a lot of other charity activities. And we are part and center of a lot of other CSR initiatives. So we collaborate with a lot of people, like Mahindra is one. Then some of our investors collaborate with us to do many of the ESG. So ESG is something which is core to our heart. It is not just, we are actually, if you see, we are not among the top 1,000 companies on a stick.
But your name is in...
Yeah, but still we do it. We are not legally compliant, if you see the rules, because, we are not among the top 10, companies which are stock market listed.
One day you'll get there.
Yeah, of course we'll. But still we manage our ESG. We manage our charity compliances. We, in fact, oversee that.
Thank you. The second last question. Anuj, if by 2047, if care shifts upstream from treatment to prevention, hospitals may no longer be judged by mortality and morbidity, but by how well they keep people out of the hospital. In a setting like yours, where access and affordability are critical, how do you build an outcome framework that extends well beyond the hospital walls?
Thank you, Ahmad Saab, for the question. Basically, the 2047 also focuses on NCDs. So these are all, you can say, communicable diseases, or you can also say as lifestyle diseases, and many other things. It is prudent to track those diseases wisely. How? Nowadays, there was a time with Apollo hospitals when I was there, we were tracking on predictive analysis, IoTs, on these things parameters. We used to do health checks and multiple for thousands and lakhs of people. With the consent and prior permissions and everything, the data was recorded. Data analysis and mining was done, and a calculative approaches was there. We used to check the scoring system of the human body, and we used to correlate how in the near future, what probabilities can happen with this thing, number one. Number two, there are multiple diagnostics and other chains which are coming up, and they are there. A thought of DNA mapping is also going on, which also do a retrospective predictive analysis, which is generally happening to hold on. In the near future, what we can say, analysis and interpretation will be vital. For that, we need tough data records and a thorough analysis of the data. For example, again, if a male around between 40 to 60 is having some ill habits in style, there is a hereditary tendency of HTDM, IHD, and heart problems, sugar, BP, or any other sort of ailments which is aligning to. So there is a record with the hospital which can be stored and reviewed with the proper consent from the patient, and an analysis of the history, the character of the disease which is supposed to become can be reviewed upon.
Thanks.
So the data protection and mining is very important in the near future for NCDs.
Now finally to the last question, and that's going to Sameer Kulkarni. This is one of the toughest questions of the evening. Ultimately, as a CEO, the buck stops with you for the functioning of the hospital. By 2047, 22 years from now, what does a sustainable, scalable, well-governed Indian hospital look like? Not aspirationally, concretely. What would the financial model look like? Payer mix, capital structure, return on profile. What is the single greatest risk if we do not address in the next 5 years that will mean we'll be sitting in the panel like this in 2035 asking the same questions?
Futuristic question. Thank you. I think future of hospital industry and healthcare industry in India is bright. Health insurance penetration is increasing, affordability is increasing. The main problem that we have to address as an industry is sustainability. In sustainability, there are two parts. One is environmental sustainability, one is financial sustainability. Environmental sustainability will be taken care of through whenever these companies will go public, they will have to follow ESG model, and environmental sustainability will be taken care of. In terms of hospitals, it is more of related to financial sustainability. And scalability will happen only if sustainability is taken care of. So basic model that you can contemplate is FDs give you 7% return, mutual funds give you 10 to 12% return. So if we have to be sustainable, we have to give at least 15% return. So everything revolves around this 15% EBITDA margin kind of scenario. So scalability within the hospital will happen only if we are achieving 15% EBITDA margins. Scalability across geography will happen if we are able to achieve those kind of margins. In future, what I see is these hospitals in tier 1 cities will be approximately in 2047 or maybe after 10 years, they will be around 30% margins, and hospitals in tier 2 and tier 3 will be at 10% margins. But overall group will be minimum at 15% margin. Anything below that is not financially sustainable for anyone. So that IRR has to be taken care of, and EBITDA margin has to be taken care of. So basis that all scalability will happen, or specialty mix will be taken care of, because in certain specialties GC is very high. So and in some certain specialties GC is very low, like orthopedics, cardiology, GC is very low. So all this specialty mix, everything will revolve around that. And also what will happen that there is an opportunity for these single specialty hospitals. So those will be mushrooming in near future. By 2047, we will see a lot of single specialty hospitals, lot of regional players who will use the regional scale to again drive a EBITDA margin of more than 15%. So a lot of things will change, and accessibility and affordability will definitely improve, and hospitals will grow. So in terms of that, future is very bright. In terms of risk that I see, like when I was in Raipur, Fortis had started its first cath lab in Raipur. There was no cath lab in Raipur. People have to travel to Nagpur, and many people used to die. Then Fortis started the cath lab, and now there are more than 15 cath labs. So scalability is not an issue in India, because affordability is increasing, insurance penetration is increasing, so demand side is increasing. In terms of supply, definitely there will be a scalability. But what is most important is sustainability will be there, scalability will be there. But are we able to maintain the good clinical outcomes and quality? So that is the most important thing. That if we don't address that, then in 2047, we will have a panel who will be very scared and very skeptical, because we scaled, we sustained, but we were not able to deliver outcomes. So in this, governance has a very good role to play. So what I see is that majority of the governance will be at a corporate level, and each process will be driven by respective functional departments. And NABH and people like Joy sir and other quality professionals have a huge role to play in it. And they are actually ensuring that we are able to deliver quality clinical outcomes. So that is one focus that we should not miss. If we miss that, then we will be in a very difficult condition. Thank you.
Thank you. Thank you very much.
I have a question to the moderator, because moderator should not be let go so easily.
Why?
Yeah. Moderator का काम ऐसे नहीं छूटना चाहिए. I want to ask you one question. What kind of healthcare system do you see or foresee, in just 2 lines, in 2047?
Sustainable, scalable,
No. ऐसा
and
word
accessible.
नहीं. आप बताओ, एक flow बताओ.
अरे बता दीजिए. Sustainable, scalable. Now he's going to come up with one more.
No.
Shoot.
You are asking a question to a consultant. He should not give a fees to you first, that you pay this, then I'll answer.
Okay, yeah, okay. We are done. Thank you everyone on the panel. Thank you for the audience. And big thank you to my team that did research on each and every one of them to get me the right questions.
Okay.
Thank you.
Thank you to our moderator and all distinguished panelists for such a valuable discussion. The perspectives shared on scalability, governance, resilience, and outcomes have given us plenty to reflect on. I would request all panelists to kindly remain on the stage for felicitation and a group photograph. May I please have Mr. Farooq Sheikh to felicitate all the panelists. And let's keep the applause going. The moderator, Dr. Ahmad S. Mecklai, founder and CEO A Healthcare, Mr. Joy Chakraborty, Chief Operating Officer, PD Hinduja Hospital, Dr. Akash and Rajpal, Healthcare Leader, ex-CEO, Jaslok and Masina Hospital, Dr. Karmakar, CEO, SPF's HMN Hospital, Saurabh Gupta, Regional Director, Mumbai KIMS Hospital, Dr. Anuj Tiwari, CEO, Lata Mangeshkar Hospital, Dr. Sameer Kulkarni, CEO, Dr. LH Hiranandani Hospital. Let's applaud for all the panelists. Can we have a group photo?